Okay, you ready?
Yeah.
Okay, go ahead.
Peekaboo, a histopathological surprise. What will be your probable diagnosis if a 10-year girl presents to you with a complaint of on and off lower lid swelling? Probably a case of challengia, right? But what if a 68-year-old lady presents to you with same complaints? Maybe orbital fat prolapse, right? But if a 28-year-old lady presents to you with similar complaints, will you still treat her as innocuous inflammation with medical management? Let's find out. So, a 28-year-old female presented to us with complaints of redness, occasional lower lid swelling in left eye, and on a busy Monday OPD, my inner general ophthalmologist was just about to disperse the case with medical management, considering it as a blepharitis. But right then, my inner oculoplasty surgeon asked for examination in Baum's view. Now here we go. We had our peekaboo moment with this cute little well-defined 12 into 30 millimeter firm, mobile, non-tender mass over inferior orbital rim. As a protocol, we advised patient for imaging, but it was deferred by her as she was expecting at that point of time. So we decided to follow the logical algorithm and started thinking about clinical differentials. We had wide spectrum of DDs in our mind, starting from benign lesions such as cavernous hemangioma, venolymphatic malformation, benign fibrous hematoma, neurilemoma, to the malignant masquerades such as soft tissue sarcoma in our mind. But since it was a well-defined lesion, we decided to go ahead with complete excision biopsy. After a subciliary transcutaneous incision, suborbicularis dissection was done, and to our surprise, tumor was encapsulated within multiple thin capsules, which was separated layer by layer, and cryo-assisted tumor delivery was done with bipolar radiofrequency probe. After hemostasis was achieved, layer by layer closure was done with 6-0-fluorine continuous sutures. Our struggles didn't just end here. HPE picture confused our pathologists as well, as it showed very rare pattern of nests of epithelioid cells separated by thin vascular channels. So now IHC came to rescue, which was positive for HMB45 and progesterone receptors. As markers were positive for both melanin and smooth muscle cells, tumor appeared to be of myomelanocytic cell lineage, and finally we reached to our diagnosis, which was perivascular epithelioid cell tumor, PEComa, peekaboo of a PEComa. This is the 3-month post-op picture suggestive of excellent cosmetic outcome without any residual or recurrent lesion. Only 10 such cases have been reported so far, out of which 8 were seen in orbit and only 2 cases were seen intraocular. The term PEComa was first described in 1992 for a lung tumor. It was then in 2005, that is 13 years later, described in the orbit for the very first time. Diagnosis is usually on basis of histopathology and immunohistochemistry. Clinical findings and radiological characteristics remain ancillary. With only a handful cases of orbital PEComa in the literature, there are no clear guidelines for the management available with us, while excision followed by close follow-up is necessary in benign cases of PEComa. Additionally, additional chemotherapy might be required in malignant cases. These are my references. Thank you.